On this episode of the Creating Victory podcast, host Amy J shares an interview with renowned cardiologist and internal medicine specialist Dr. Hooman Yaghoobzadeh. The interview was filmed during Amy Jordan's New York congressional campaign in early 2026. She and Dr. Yaghoobzadeh explore possibilities of a more equitable healthcare system, address truths and misconceptions of weight loss drugs and GLP-1s, and the power of overall wellness in disease prevention and management.
Dr. Yaghoobzadeh.
So nice to see you, Amy.
Friends, I always say, Dr. Yaghoobzadeh literally mended my broken heart.
Thank you.
That was in 2010.
Wow, time flies.
I know, in the middle of everything that was going on.
Time flies.
So you have a background in?
I'm an internist and a cardiologist.
Amazing. Here at Weill, Cornell.
Yeah. Practice on the Upper East Side. I have a, practice of about 2,000 patients or so with internal medicine, cardiology, and new consultations.
So you've seen a lot of change over the years. And, I'm curious about a lot of things because I was referred to you in a frantic moment.
Yes.
In a desperate situation. Dr. Hartman was like, you need to go downstairs right now. There's so much technology and so much ever evolving. And one of the things I love about you is you're so holistic about just the body and life, and how I would come in and you would say, how are you sleeping? How's your social life? Are you dating? And I'm just like, what the hell does that have to
Yeah.
Really? I mean, you have such a unusually holistic perspective of medicine for...
Yeah, it's all related. And that's one thing I love about doing internal medicine and cardiology, that you can tie all of those things together. So if you're exercising, how you're eating, what your sleep quality is like, has effects on your cortisol levels, inflammatory markers, and so on and so forth. And so if you're taking a bunch of medications to move your physiology in one direction, if you are doing all the other things that you're supposed to be doing, then the medicines work better, you end up being on less medicines. And it also, helps develop a relationship with a patient. And the therapeutic relationship may be the most important tool that a physician has to sort of, move health in the right direction, change habits, relieve anxiety. That's one of the main functions when folks come in, so they feel less anxious when they leave. But that's going to happen if they trust the person that they're, with. And so that's all part of that.
The whole reason I decided to run for office was because I went to the pharmacy. Not the whole reason, but the main reason is the health care, the non-coverage of my medication, $600 of the insulin. I'm in a very fortunate situation where I have people like you and Dr. Bragaman and others, Dr. Rahab. But as a physician's side, because I think you guys also get the short end of the stick of the way the system is set up, and we don't hear about that. So how does that affect how you've had to redirect your practice? And
you're seeing it's a significant trend across medicine in general. When I went out into practice, there were very, very few physicians that were working outside of insurance, outside of Medicare. And conversely, there were very few patients who were willing to pay out of pocket for that kind of service and time and so on and so forth. I think there are outstanding physicians who take insurance. There are outstanding physicians who are outside of insurance. There are mediocre physicians who take insurance, and then there are mediocre physicians who are outside of insurance. And so I think it's not the quality of the physician in any way. When you go outside of insurance, several things happen. The main thing that happens for the physician is that the time and money that you need to spend to fight with insurance companies, to collect payment, and so on and so forth. What folks don't understand necessarily about medicine is that, when you go to get any other service or buy any other thing, you have a direct financial relationship with the person that's giving you the service. You go to the mechanic, you pay the mechanic. You go to the hotel to stay in a hotel, you pay and so conversely, the person that's giving you the service is fully incentivized to improve your experience and make sure that you come back and you tell all your friends and so on and so forth. And that's how a free market capitalistic kind of situation works. In medicine, there's a third party payer. So you come, you get your care from me. I then have to send a bill to the insurance company. The insurance company says you didn't create the right note, you didn't, qualify the note that you spent this much time, you didn't ask about smoking, and therefore we're not going to give you what you asked for. And so then there's a lot of back and forth, and all of that administrative time takes up time, employee space, and money. So when you come out of insurance, you don't have to think about that. And then that allows you and frees up your day to be able to spend as much time as you want, practice medicine, and not do all the other stuff. And so, unlike when I first came out, when there weren't many physicians doing it, and there was also not many patients willing to pay for it, the only patients that were willing to pay for it were the super wealthy. Now, it is so frustrating for both the patients and the physicians that not only are a lot of doctors going out, but there's a lot of patients who say, you know what, I know that I'm going to need to pay this much out of pocket. I'm just going to I already paid this much out of pocket for a nicer pair of shoes or this or that. I'm just going to. Now, that's still a small percentage of the full patient population. And so creating this kind of system theoretically works for larger populations as far as, things that the government can do to make it easier for physicians and patients to interact in a way that they don't have all of the other obstacles. And so that would then create, better incentives to give better care and so on and so forth. So a lot of the prior authorization stuff that happens is pretty crazy now. And so that's one. Alternatively, creating alternative models. For example, there are health savings accounts. One thought experiment is that as of 8 years ago, the last time I looked at this, we spend for every single American somewhere between $10,000 and $11,000 per year on healthcare for every single American. It doesn't matter if they were sick, but on average, that's what it averages out across the population. You need insurance for catastrophes. You insure your house for what happened to you. You insure your house against a fire. You insure your house against a flood, for example. You don't insure the electrical bill in your house. You don't insure the fact that you may need new cutlery every so many years. You insure for unexpected kinds of situations. Everything else you save for. You save for, you pay for, you budget for. And so let's do the thought experiment where if everyone had to have like a universal catastrophic coverage, where if your yearly healthcare expense is over $20,000, for example, or
injury.
Exactly. Or your lifetime, you can even sort of think about it as a lifetime expense. If your lifetime expense goes above whatever many hundreds of thousands of dollars, catastrophic insurance kicks in. If everyone has to buy in, and when I say everyone, I mean employers have to get it for their employees, patients who can afford get it for themselves, folks who are unemployed who can't afford it, the government puts it in the same way that the government is subsidizing Medicaid and all this kind of stuff now. Catastrophic insurance costs somewhere around $2,000 to $3,000 a year because catastrophes are very infrequent.
Right.
So that leaves
serious.
that leaves $7,000 a year that you could put into a health savings account every year from the day you're born. Your parents can put it in, employers, government, and it can roll over year over year over year. You never lose it. You can create constructs where it's tax exempt, where the income on it is tax exempt. So you're incentivized to not spend it and so on and so forth. And then go and shop for healthcare. In that kind of situation,
Can afford it.
you could easily afford it. It's never going to be easily affordable. Healthcare is expensive. We spend a tremendous amount of money, a third of our GDP.
$601.99 for my little Traceba pen.
One reason why the Traceba pen is so expensive is because the drug company who made it rightly should charge what they can for it and so on and so forth. They're not selling it to you. They have a deal that they've made with a third-party payer. And the third party, and not only is it a third party, a third party payer, the insurance company, but then there's a pharmacy manager. There's another man. So think about the number of, everybody has to make money on this deal. It's crazy. Whereas the only two people that should be involved is you, the person who's getting it and the person who's giving it.
That's it.
And that's it.
Policy.
Yeah, and
Would you like to write healthcare policy?
David Goldhill wrote a book called Catastrophic Care about maybe 10, 15 years ago. And he goes through this and he works out the numbers. He like creates. So it's definitely, I would recommend you reading that. I'll text it to you afterwards, Catastrophic Care. And so in that way, you have the catastrophic care insurance, you have your health savings account, and then it would incentivize good behavior. Meaning, like, think about the number of patients, and I see it all the time. Patients come in and they're like, I had a headache last night. I want an MRI. And I'm like, you don't need an MRI.
They went to Dr. Google.
Right. You don't need an MRI. But because it's not coming out of their pocket, because Medicare is paying for it, and Medicare doesn't need prior authorization. That's one nice thing about Medicare. Insurance companies need prior authorization to avoid this kind of behavior, right? But if the MRI had to come out of the pocket of the patient, then they wouldn't be so quick to get an MRI. Not only that, they would shop around and figure out who can do a good MRI and a little bit cheaper. And before you know it, MRIs wouldn't cost $3,000.
Or have I had enough water? Or do I take a time?
Right. Why is it that for every other thing that we do in this country, capitalism has figured out a way to get the most efficient, the least price that you can. And by doing that, it also creates higher quality. So the other thing, and I'm sorry I'm doing all the talking.
This is amazing. I'm completely fascinated from a policy perspective.
The other piece of it is, so, people say, wow, like, how do you control costs in a situation like that? And the idea is that you don't control costs by some, overarching organization saying this is what this ICD-9 should cost, which is what happens now.
Like the line items, this is going on with the CGMs right now because they don't want to keep, it's crazy and it's going to end up costing the system. It's catastrophic for people like me.
Yeah. And so what happens in that situation is every year there's a congressional committee that meets behind closed doors to go through every single ICD-9 code. And they say, we're going to pay cardiologists this much for an EKG. We're going to pay cardiologists this much for a follow-up visit. We're going to pay a CT surgeon this much for surgery. And then insurance companies take those and they say, okay, we'll reimburse at 2 times that, or we'll reimburse at 1.5 times that. And then that's where sort of the foundation, and then there's bartering back and forth through insurance companies and providers. And the larger the provider you are, the more leverage you have, and so
more lobby money.
Right, but that's how you spend. And so what the price of something is in medicine is just like a number that somebody has picked out of thin air. It has nothing to do with the value. So back surgeons who their surgery can be spectacular, but for like spinal stenosis back surgeons have a very, very strong lobby. And so they have figured out how to make, and there's very few back surgeons in the country. They have created a situation where they get reimbursed at many, many orders of magnitude more than heart surgeons when heart surgeons do bypass, even though Heart surgery has been proven to extend life, proven to save lives.
My father had a quadruple.
Yeah.
Me.
Yeah. And back surgery, it's unclear. Oftentimes, back surgery is actually not successful for spinal stenosis. And so the price of things are picked out of air in a way, and then have to do with lobbying and negotiations and so on and so forth.
Who gets the contract?
Right, exactly. But when you think about
formulary change, so now that's what happened. We want you to take Lantus.
Exactly. It's like the decision is taken out of your and the doctor's. Yeah.
Yeah.
But if you think about the price for anything else that you do in your life, let's think about cars. The price of cars is determined by the market. And because there's competition, there are very expensive cars that have bells and whistles. But the beauty of that thing is that even if you go for the least expensive car, because there's competition, the Hyundais of the world have to compete with the Hondas of the world, who have to compete with the Volkswagens of the world, who have to compete with the Buicks and the So they all have to get better and more efficient. There is no competition in medicine whatsoever in that way where you're competing for the people and they're the ones that are giving you the money. So the quality in medicine, it's very hard to know. In fact, in an open market, you can blindfold yourself, walk into a car dealership, not know what car dealership you're at, but you are almost guaranteed that the more money you pay, the better car you get. Right. And that even if you spend the minimum amount of money, the car is going to be safe. It's going to have past standards. It's not going to fall apart on you. The companies doesn't want to get sued, and also they want to sell cars. So you know that you're getting a decent product. That doesn't happen in medicine. Like if you say, I want a better doctor, or I want for this thing, I want to go the extra mile. You don't know how to do that. It's all word of mouth, who the good doctors are. So an open market is a way to better streamline medicine, improve quality, lower expense. No system is perfect. So there are some things that you have to protect against. You have to protect against the catastrophic stuff, when we talked about catastrophic insurance. You have to protect, what happens when, somebody is born with congenital anomaly, or somebody has renal failure when they're very, very young, or, Yeah. And so those carve-outs, we have currently also. We have carve-outs for dialysis. So those all together, like all of those situations that feel like non-equitable, not fair, I got sick, it wasn't my fault, they make up for a small part of all of the expense. So you would save a lot of money, and with all the money that you've saved, you can create all of those kinds of carve-outs and so on and so forth. But
amazing. I never looked at it.
And the reason why I think most folks don't talk about it, haven't heard about it, and this may sound like a conspiracy theory, but I don't think it is.
Yeah.
If it's
true, it's not.
In an open market, all vested interests currently lose. Meaning, in an open market, doctors have to compete. Hospitals have to compete. Drug companies have to compete. They have to price their products, in a situation where they're competitive with somebody else. Device companies have to compete. I have an iPhone, right? And this iPhone is like a supercomputer. It can do so many things. This iPhone, I don't even know how much it costs, because somehow it's like in my phone plan. I think it's free, but it probably costs like $1,000, right?
They're about $1,000.
Yeah. A pacemaker that is basic technology. It's a battery, a transistor, some minor programming.
Right?
They're pretty small with some wires. The device itself, forget about the procedure, forget about the doctor, forget about it. The device itself costs $10,000. Why? Because there's 3 companies that make the device companies, and they have relationships and figured out how to lobby and create barriers to entry, and they don't have to price their device to sell. Well, if there was an open market, you could for sure believe that, and every year they go to Medicare and they say, oh, look at this new pacemaker that we have.
It has a new wire.
It has this, and it has this, and it has this bells and whistles. Meanwhile, 99% of the stuff that it has, we don't use, we don't need, it doesn't really help. And you could easily envision a situation where a new device company says, you know what, we can make a pacemaker for 1/5 that price. Yeah, maybe it's not going to have all of the remote monitoring, and it's not going to.
They're the same.
Yeah, but the basic, like, needing to pace your heart so that your heart doesn't stop is there. They can create, and so, but there's no incentive to do that. There's no one wants to make a cheap pacemaker.
This is amazing.
So, like, all of a sudden, you start to realize, wait a second, medicine is an island economy.
Oh, yeah.
It's like people who live on an island that have never been visited by anybody else, that have never seen anything outside. You have no idea what's out there.
Right.
Somehow we think of medicine as this completely thing that is different than everything else. Meanwhile, it's just about products and services, and we do products and services for everything else. The one argument that used to be against having an open market in medicine, when you talk to economists and you talk about open markets, they say that open markets work if there isn't much information asymmetry, meaning that, like, if the doctor has all this information and the consumer, the patient, doesn't have anything, any information, they didn't go to medical school and so on and so forth, then the doctor can manipulate the situation and so on and so forth.
Abuse of the system. Right. Yeah.
Yes, there's information asymmetry, but do you know how your car works? Do you know,
how
why?
Your iPhone works?
Yeah, how your iPhone works.
No.
When you go to the mechanic,
and
when you go to the mechanic and you give your car, do you know that they're not ripping you off? Markets figure out ways where quality comes up, and folks who don't, do the right thing get taken care of. There are rating agencies. We go around and we make sure that restaurants are healthy places to eat. We inspect them. There are 101 ways that you can make sure that you have basic quality and so on and so forth, that folks are not cheating the system and all that.
And the doctors too.
Yeah. And then the last thing about information asymmetry is artificial intelligence.
Oh, this terrifies me.
But artificial intelligence and Google and internet levels the playing field. Yeah. So when the doctor says, I think you need a cardiac catheterization, you can literally put your medical history into AI and be like, is that reasonable or not? And AI will tell you, this is standard of care. This is outside of standard of care. This is malpractice, So the information asymmetry argument is not really an argument anymore, especially in medicine.
With this now, with the Dr. Google.
Now, unfortunately, going back to where we started, which is people going outside, doctors going outside of insurance and patients going outside of
is too.
Right.
He said, I'm a specialty. I have to go lobby because they just want to pay the hip replacements and the knee. But if someone like me comes in, this is all he does. Yeah. So that becomes problematic because it's so niche.
Yeah.
It's just all these layers to it.
Yeah.
And he's going out of network.
Yeah. So unfortunately, what's happening with the out of network stuff is we're moving towards an open market system. Because this then becomes an open market.
Right.
You can decide you're going to come see me. You can decide I'm going to go see somebody that's less expensive. You can decide I'm going to go see somebody that's more expensive because I want more time. I want a fancier office.
And the guy that has 8 patients, I can't imagine with that cost.
I want them to be doing, VO2 maxes all the time and so on and so forth.
Why?
So we're moving, exactly. We're moving towards...
Can you explain what a VO2 max is?
It's how efficiently you use oxygen to create energy for your muscles, which is dependent on the heart and lung and so on and so forth. But we're moving towards an open market system. However, only for the very, very upper income levels, which is the definition of being unfair and not equitable.
Is the challenge.
And so as the better physicians go towards out of care, what happens? All the other physicians that have to deal with insurance get more burden and more burden.
Less time.
And all of those patients that can't afford because they don't have health savings accounts, because health savings accounts have not been funded for them and so on and so forth.
They're not on insurance.
They have less time with. So what's happening is we're getting a 2-tier system where patients who can pay do, and patients who can't get, hopefully optimal care. But as this part of the system becomes more and more and more burdened, you spend less and less time with your physicians. And so that's, now how we get from here to there, we need to start talking about it. We need to create a conversation so that we at least know where we want to try to go.
Can we talk to each other, please?
At least, we have like a North Star. At least we have, well, we can't just change tomorrow because people who are 40, 50 don't have the health savings account that they've built for 40 years. And think about it, like the first 20 years of your life, you're relatively healthy, the minimal kinds of, for most folks. In that kind of model, you could also share health savings accounts. So you can create a situation, a thought experiment where you and your family or like-minded friends who you have agreed together. Yeah, we don't smoke. We live healthily. We eat well. We're going to share our health. We trust each other. We're going to share our health savings accounts so that we know that on average over time, we don't have to worry so much if I've had 5 years of savings or 20 years of savings. And businesses can share health savings accounts. And so there are many different ways. There are many ways to sort of create safety nets. But we can't come up with those solutions if we continue to do the same thing over and over.
This is the problem with insurance lobbies and all of this comes in. And, money and the money. We're finding out. This is amazing.
So we were talking about who the vested interests are and that everybody would need to compete and give a better product at a lower expensive price. So therefore nobody wants it. The one person that benefits in an open market system is all of us.
Right.
Because we're paying for it.
Yes.
We can't educate our kids. We can't fund the military to the level that maybe some people would want us to be funding. We can't build the roads that we want. We can't do so many things because so much money is going into medicine and it's being it's like a sieve. It just goes through. Yes, exactly.
Yeah.
And the answer is not throwing more money at it.
No. Wow. You sure you don't want to become a policy advisor? Would you be my policy advisor?
David Goldhill is the healthcare policy advisor that you should ask because he's the real brilliant
numbers
guy.
I call him. So
he's the brilliant guy.
I want to segue for a second off this. I heard you on the phone when I'm in your office trying to not get high blood pressure with patients who are not making dietary changes and wondering why their situations are not improving. This is, people ask me all the time, I don't really deviate off with them.
Yeah, it's hard.
Once in a while.
You work hard.
But it's a lot of work.
And there's a lot of sacrifice.
Yeah. Well, I tell Dr. Bragman I won't be crippled and fat, so it has less to do with my rehab and diabetes and more to do with my dancer neuroses, but that's a conversation for a psychiatrist. So the answer is it never stops. So with this food pyramid situation,
yes.
which I think is great, but I'm not a doctor.
Yeah.
And, we had talked before with the sweet enough stuff that I was doing with the kids about the processed foods and the fast foods. And what do you think about these changes that
it's
fat? It's very complicated.
So I would say the most important rule when it comes to diet is stay away from processed foods. And the current food pyramid and all the messaging around it goes along with that. They really want you to stay away from processed foods. And just to be clear, because it's not exactly clear in the food pyramid, sodas are processed foods.
What happens physiologically, like if you drink a Coke?
Yeah, well, processed foods oftentimes have lots and lots of simple carbohydrates. So sugar increases blood sugar levels, increases cortisol levels, increases insulin levels. All those hormones are also related to plaque buildup, high blood pressure, stress, inflammation, cortisol and insulin, joints, and so on and so forth. So processed food has high sugar, oftentimes has high salt, oftentimes, especially the stuff that we all crave, like pizza foods, and chips and Doritos, also has fat. So when you combine sugar, salt, and fat, that triad, that's what we crave. That's like crack. We all want it.
And that tips off the
and I use the cocaine analogy intentionally because they're literally addictive. And the more you eat, the more you want to eat, and the harder it is. And so from a very young age, trying to limit processed foods in our diets, in our schools, in our hospitals.
Well, the famous story when I went, actually on the burn unit, they were pretty good. And Dr. Spector was always yelling at me to eat my egg whites. Otherwise, it wasn't going to get better. But when I went into the nursing home the second time, I remember because of my osteomyelitis, because Medicare would pay more money for me to be in a nursing home than for do a PICC line and send me at home with it, that was a whole other thing. Yeah. But they came in with pancakes and pineapples. No, this is a true story. Yeah. And I literally, I think it was the January, February, March of 2010. This was before you, actually, when they took out my hardware and Dr. Lord said, we don't know if you're going to be able to walk. Yeah. We have to do a bone graft, and it's really not good. We had to take it. And I'm like, I was just like, shoot me now. I really just wanted to die. And then I get to the nursing home. So I literally started to cry, which I don't do very often.
Uh-huh.
And I said, did anyone look at my chart? Like, I'm very,
right.
He's like, oh,
Yeah.
Oh my God.
Yeah.
I don't know why I started on that.
Yeah, well, the processed food, so they get that right.
The hospital thing.
The hospital thing.
Yeah.
So lowering processed food is extraordinarily important. And the diet for a type 2 diabetic may be very different than, they're not going to be as tightly carb sensitive.
And a very one size fits all.
Yeah, exactly.
And I've been saying this about a lot of issues lately where people ask me, and so it's way more complicated than that.
Yeah.
We
used to have this kind of pyramid. Now we have this kind of pyramid, but the one in between, right? Yeah. The one in between was a
plate,
which even conceptually, like what you're talking about, it's not like something is necessarily better than something else. There's okay, these are the things that you should try to keep on your plate. These are the things that you should try to keep off your plate. But yes, any push towards lowering sugar, lowering processed foods and chemicals and food dyes and all that kind of stuff is well directed.
Yeah. Diet Coke.
Yeah, so Diet Coke is that right? Yeah. Diet Coke is also not a good thing. So several things.
It's almost worse,
First of all, soda is extraordinarily acidic. So it's a very high acid load. can of Coke has a pH of 2, I think, or 2.4, whereas like, orange juice, which is pretty acidic, or tomato has a pH of something like 5. So, and each pH is 10 times more acidic than the one number above it. So 4 is 10 times 5, 3 is 10. So 2 is like 1,000 times or whatever, you do the math, compared to 5. And that acid load, then your body has to filter through your kidneys and liver. It leaches calcium carbonate out of bones. It's related to osteoporosis. So the acid load is a problem, 1. 2, multiple studies have shown that even though a diet flavoring would spike your sugar in the same way that sugar would spike your sugar. And again, let's take type 1 diabetics out because there are exceptions. And a type 1 diabetic, if they have a choice between diet or sugar, it should be diet. It should not be the sugar, because sugar really is enemy number 1 in a type 1 diabetic. But in all other folks, when you do studies and when you give people food, same food, 1 regular sugar, 1 diet, and then you see what happens over the next month, those folks who have the diet, even though initially they're taking in less calories, less sugar during the day, ultimately their body adjusts and they will crave sugar even more and find an extra cookie here, an extra snack there. And at the end of the day, it turns out that the total amount of sugar that folks have had is if at the very least the same and maybe increased in the folks that are having diet. So I'm not a fan of soda, period. It doesn't matter diet or not. Which, my mom used to tell me all the time when I was in medical school and even like in residency, stop drinking soda. And I'm like, give me a break. It's fine. Warren Buffett does it.
Warren Buffett. Yeah. Oh my God.
But, moms are right more often than they're wrong.
I drank Tab. I was really into Tab when I was a kid, but that was the 70s. So.
Yeah.
But, and I've also noticed in myself when I'm getting the fat and the protein, then I really stop craving
the
sugar, period.
Yeah.
I mean, I get situations related to a chemical binge or whatever if I get some hypoglycemia, but that's a separate. But I'm like, I just don't want it now.
Yeah.
And I've been doing this for a long time, and it just doesn't even.
Yeah, the sugar is really
to
addictive, and then when you cut it out, it becomes less so. If you
having to eat consistently and get the right things.
Exactly.
And you're like, I didn't eat all day, and I was like, well, no wonder you had a box of Oreos.
Yeah.
Like, it's not your fault.
That's exactly right. If you give mice access to cocaine water or sugar water, and the mice can choose which one they have, they will more often go for sugar water than they will for cocaine water.
Wow.
Sugar is extraordinarily addictive. And we have a whole economy based on
sugar and marketing.
And
oh, yeah. I saw once, this was a while ago, I was flipping channels. I think it was MSNBC, actually. Like, don't quote me on that. I saw a commercial for Hershey's, whatever, chocolate.
Yeah.
Brainwashed.
Yeah.
It's so subtle, but here, go have whatever you want. Here, get a,
Yeah.
I mean, do you, wasn't really on my radar, but as long as it's come up to you, what do you think about these? I mean, and people are like, I'm taking the shot. Somebody said that to me, and he's not that overweight. He's maybe 70, had some cardiac stuff, and then his doctor said, well, you put on like 10, 15 pounds, not like 100 pounds. And well, she's going to put me up. And, sometimes I just, out of auto response, don't hold my tongue. And I said, well, just cut out the carbs and sugar. Right. He went, and then I had to just zip it because I'm not a doctor. But I don't know. What do you think about this take a shot craze rather than put down the fork and
Absolutely. So what I tell patients is that the medications are not magic. And so they will lead to weight loss pretty much in all folks that use them. However, if you're not being very, very mindful of what the shots are allowing you to do, your body will get used to the shots, the weight will come back. If you ever come off the shots, the weight will come back and more. But if you take the shots, and because it's taken away the food noise, now you're cognizant of the fact that I don't need that dessert. I don't need the extra sweet stuff.
What does it do exactly? I don't even
When I order fries, I only have 10. The GLP-1s and GIP drugs, they do several things. They slow down how quickly your stomach empties. So you stay full and you get full faster. So they satiate you. So that's their effect on the stomach. Their effect on the brain is that they affect the pathways that create like hunger, food ruminations. There are some cravings, exactly. And that also goes for cravings for alcohol. And it may also go for cravings for other things, which is, there's some interesting research. They also improve insulin sensitivity. So for any given thing that you eat, your body needs to make less insulin to keep the blood sugars stable. And insulin then is the bad actor, and insulin is a bad actor, meaning, yes, you need it 100%, and if without it, you get terribly sick. That's type 1 diabetes. You don't produce your own insulin. But
you want as little
when
as
you
really
exactly
possible.
when you have a lot of insulin, either because you're insulin resistant, because you're heavy, or you have central obesity, insulin then drives inflammation, it drives plaque, it drives high blood pressure, fatty liver, it does all these things that are not good for you. And so when these drugs make you more insulin sensitive, you can produce less insulin and keep your blood sugar stable. So they do all of those things. So when patients are very, very mindful, these drugs can really be life-changing because they're mindful. And when I say mindful, what does that mean? That means that over time, because you're really cognizant of what's happening, the neurons in your brain that are responsible for your actions, your behavior, your wants, your habits, they start to reform. You start to get motivated by different things. You start to get motivated by the fact that, oh, I can run further, I can run faster. Those neurons, memories, sleep better, I feel better. Yeah, exactly. I'm less depressed. I'm less, frustrated. Little by little, if you're truly working on it, that changes who you are.
Right.
That's the brain. That's what is beautiful about it. So, but I tell patients, if you take the drug and you don't change what you eat, how you eat, who you eat with, where you eat, when you eat, if you don't change any of that stuff and you just limit the number of calories, but you're eating the same stuff, processed foods, you're, snacking time of eating, you're eating at the same kinds of restaurants, the same kinds of folks who have certain eating behaviors that maybe are feeding into your eating behavior. If you don't change that, then the medicines will stop working very quickly.
It's like people say, oh, I'm fasting, but then they have pancakes and,
Right.
and I'm like, well,
Right.
it's okay.
Yeah.
Good luck with that,
Yeah, exactly. So they're good. They're
They're
miraculous drugs. They're miraculous
in the right
drugs.
situation,
Yeah.
the right model. Because you're
Yeah.
seeing a lot about it now, and it's become like a celebrity hype, and then all of a
Yes.
sudden it's like Instagram famous, and
Yeah.
I just think it was social media.
You've, taken agency of your own health. You're doing something to make yourself healthier. That just the act of taking agency has tremendous effect, because then you'll also pay attention to your exercise and you'll also pay attention to your diet. So
Crippled and fat.
yeah,
Now we'll still do that. Dance and neuroses. I don't know. This is amazing. Anything else we need, Director?
I'm learning. I learned so much just listening. I'm never drinking soda again. That's what
That's what he always says.
Good. So
I see it all the time. I go out to eat with, I have family members that are just struggling with a lot of, I can't go out to eat with them anymore, actually. Like, eat a basket of bread and then be like, oh, I'm sleepy. Oh, I think it's a flu. And I'm like,
Right.
you just said about you're having a hypoglycemia. And then complain, I'm hurting. I don't feel good.
Yeah.
I'm then sneezing.
Yeah.
I don't know what you want me to tell you.
Right.
So it's so much behavioral, and
Yeah.
we're so sort of brainwashed by media, and
Yeah.
social media.
Yeah.
Take the shots, and then
Yeah.
just keep going.
Well, listen, you've always...
Oprah does it.
Yeah. You've always been an independent thinker. You've always thought outside the box. You've always said, okay, to the best of my ability, these are my options. This is what I have to play with. And I understand that these are the recommendations. What do I need to do that's right for me? And you've navigated very, very appropriately. That's why you're sitting here with two legs and, not in a very different situation. And so it takes a tremendous amount of work and courage. You're doing that now with, the decision to run for office, takes a...
Explain how bad it was when you were there.
How bad it was when you were in the hospital with the leg? Well, I wasn't there when the accident happened. I came by, I think about a year later, maybe 6 months to a year later. Oh, it was a horrible
And how does that
situation.
play into her mindset for running for office?
Yeah, that's a very important point. So,
Sometimes I need reminded it was really bad because I think I'm overplaying it. I like trying to get attention, or I like the letter, thank you for that, because they're not letting anyone in to help me.
It's horrific on so many different levels.
And
First
it
of
could have
all,
gone way different.
First of all, it's just horrific pain. And anyone that sits here and says, well, I could have done that, many people, you have that level of pain, you give up. One of the main objectives of the way that we're wired head to toe is to avoid pain. It's like the basic reflex that you go away from being burned. So you were able so first of all, the pain is horrific. Second of all, the unknown, you're looking into the void. You don't know what the future has to offer. And so many of us, it's like windsurfing. You throw your kite out there or and that the wind is going to take you. And the future, having some certainty about your future, is the wind, which is hope that, brings you to the next day and keeps you going and so on and so forth. You don't, when something like that happens to you, you don't have that. You have to just believe. You have to have faith in yourself, and personal strength, inner strength, that you're going to come out on the other side, and because you have no choice. And so A, you have horrific pain. B, you are robbed of tomorrow's certainty. And so that's really, really scary. And so to be able to navigate at that point in time and make decisions is amazing and speaks volumes to your ability to make decisions in real time, actually.
And can you just mention because of your accident? Because we're not.
Oh, yes.
It's not the movie. They don't know any of her backstory.
Yeah.
You have to say the whole thing, but just some more about that because of your accident.
Yeah. And so because you went through that, because of your accident, because you, after your accident, had to make those decisions and be confronted with that in real time, you are somebody who's capable of making decisions, being definitive, having options in front of you that none of them are great options, which is maybe the definition of politics, and coming up with the option that's the best. I said once that you're
cynically optimistic.
You're cynically optimistic. And I think a cynically optimistic person is like the perfect politician, right? You have to be a cynic, because if you're gullible, if you don't question things, if you just take things at face value, then, you're not going to get far in furthering other people's interests. But if you're a pessimist and the cup is half empty and woe is me, then you're also not going to lead to a better tomorrow. And so cynically optimistic is
That's going to be the title of my next book.
The next campaign.
Yeah. We are cynically optimistic. Come join the cynical optimists.
It's kind of melancholy now.
I think it's a good, emotional stamp for today's world. If we can just take all the, if everybody could be just a little bit cynically optimistic. Don't be a cynic. Yeah.
Okay, one personal thing and then we're done. Speaker phones, yes or no in public?
No.
Thank God.
No.
Thank God.
It's terrible, especially in the day of you put something in your ear.
It drives me crazy.
Yeah, I agree. Absolutely not.
When I get elected, I'm banning speakerphones in Congress. Amy Jordan, independent sort of candidate for Congress. Well, I can still say that. Thank you.
My pleasure.